This is Still on Health with Mario. Envisioned by the people, voiced by the people, powered by the people. It's everyday people with extraordinary values that make up New Right Network. Welcome to the healthcare voice of New Right Network. This is Stealth on Health, and I'm Mario Nastanovich. Joining me for episode number 14 is a 30-year industry veteran and recognized financial leader in collections, debt buying, and outsourcing. He maintains expertise in creating breakthrough results in customer retention, free cash flow, and profit through customer-centric cultures, effective communication, and optimization of people, processes, technology, and metrics. His career includes employment and consulting assignments with IBM, Johnson & Johnson Healthcare Systems, and numerous collections agencies. He possesses his undergrad in finance and economics from Florida Southern College and received his MBA at Pace University. He's the co-founder of RIP Medical Debt, a nonprofit designed to buy medical debt portfolios originating from hospitals or doctors on the secondary debt market with donated money, and then the debt of resource-challenged individuals is cleared to free them from the stigma and stress of the collections process. Welcome to the 14th episode of Stealth on Health, Mr. Craig Antico.
Thank you, Mario. It's a pleasure to be here.
So, Craig, let's start off with the easiest question there could possibly be in this milieu of medical debt. By definition, what is medical debt?
Medical debt is the amount of the bill that's remaining that you're responsible for and you can't pay.
And how
There's
big is
about
it?
$1 trillion of medical debt
How big is this
outstanding in this country.
How big is it?
$1 trillion, if you can imagine. Now, only about 80% of that is from people that can't pay, that are, resource challenged, or they're in, such hardship that they can't pay their bill.
Now, who within our population are considered the most vulnerable? And are there any particular cases, familiar cases, minding our HIPAA guidelines that come to mind to illustrate this for our viewers?
Sure. I mean, the uninsured, the uninsured are probably the biggest issue we have in the country. They're the ones that they get charity care, but they don't always take it. So charity care is where you can go to the hospital and you can't be turned away because of how much you make or whether you have enough money to pay. But the percentage of debt that they have of what they owed is tremendous. They can only pay about 10% of what they're responsible for. Now, what's interesting is, although the nationwide average is about 10% of our population is uninsured, for communities of color, that's over 16%.
Wow.
So it's a tremendous difference. White communities have about a 7% uninsured rate. So it is affecting, the communities of color, which is unfortunate. And it's affecting most of the people in the South. Some of the people in the South have about 40% of the population having medical debt on their credit reports, where the average might be about 20%. So the southern portion and also the uninsured.
And then any particular cases that come to mind in terms of what may be more common? Are these individuals that are going in for elective surgeries? Are they more chronic conditions, knee replacements, hip replacements, various cancers?
Yeah, I'll tell you what's going on. I've heard from people that have cancer that have decided to stop getting treatment, even though it's saving their lives, because they don't want the medical debt that comes with it. Some people I've heard are spending 10, 20, 30% of their gross income on cancer treatments. Another area, we just bought a portfolio of medical debt that's owed by people that have addiction and mental health issues. That is out of network most of the time. You have to pay up front even before you go to the facility, which is just devastating, especially to the resource challenged people who don't have somebody to pay for them, if not them. The other things are, transplants or kidney transplants like that. Those are oftentimes the biggest expenses for out-of-pocket expenses. About 20% of all medical bills are out of network. So I hear from a lot of people that they were surprised that they got a bill when they were told that all the coverage was there for them. For example, emergency rooms across the country. You better call up your hospital and see if the doctors in the emergency room are even in your network. The hospital could be in your network and the doctors might not be. So it's preposterous that you would think that you could get a bill out of network going to a hospital that's supposed to be in your plan. So you have to call up and find out.
And just imagine in an urgent situation, someone even thinking along those lines to call up a hospital and to check if the emergency room physician that they're seeing is actually part of their plan. That I don't think that's the first thing that comes to mind for anyone of any socioeconomic class. But certainly, I also think that when you start talking about the medical debt issue, we're also talking about people who are affected by the various healthcare disparities. So one can only imagine that as this debt is incurred, these are individuals that are already suffering in many ways from many of the aspects of the social determinants of health, and it just becomes a vicious cycle because that burden of debt becomes the burden on them, their health, their mental wellness, their overall wellness and well-being. So what you're certainly doing is just a tremendous effort, and we will certainly get.
Um, Debt of necessity is like your shelter, your education, your health care. Those are things that you expect to have and need to have for wellness. Um, we've done, we've even done research with major institutions like University of Chicago, UCLA, MIT, that's trying to evaluate what is this debt actually causing people, the stress, the stigma. I mean, the poor health, mental health is a big issue when it comes to debt. I mean, I even heard something, this will blow your mind and your listeners' mind, viewers' minds. In Japan, um, collection letters were sent out to the people from the government, and they actually saw a spike in suicides
I believe it.
from from this debt. I mean, I'm talking about a statistically significant raise in that. So we don't know what's happening. We know homelessness is occurring because of medical debt. We know bankruptcies and insolvency are occurring. And these are all health events that cause, stress and morbidity, unfortunately.
Craig, let's take a step back together for those that are watching us today that may not know the origins and some of the financial structure in basic terms of the U.S. healthcare system. You and your colleagues actually wrote a book about, at least partly about this, called End Medical Debt, which we'll discuss more in depth shortly. But where do our financial problems in terms of medical debt originate historically in this country?
Well, you can go back to when wages were frozen, 50 years ago. And employers figured a way to get around those wage controls
Hmm.
by offering benefits to their employees. And health benefits were one of them. That's why employer-based health insurance is the de facto standard here. 50% of all our people in this country get their insurance through their
Through the employer.
employer,
Yeah.
which is, a tremendous difference than any other country. So that's the first thing. The second thing is when Medicare and Medicaid were introduced, it pushed doctors to try to get the most money out of the government by becoming specialists. So we became specialists, and those specialists charged much more. And the colleges started producing many more specialists. And the costs now begin to rise more and more and more. I mean, early days, as a percentage of GDP, we were well below 10% of our GDP was spent on healthcare. Ironically, back in the 50s, 90% of all healthcare was paid for by the consumer, the patient, and 10% was paid by the government. In 2000, that was up to 10% was paid by the government, by the people, and 90% was paid by the government.
Hmm.
So we flipped it on its head. But now what's happening, there's a cost shift. There's a cost shift toward the payer being the patient now. And from 2000 to now, we've gone from 10% is the payer's responsibility for the patient's responsibility. Now the patient is paying 30% of the bill. So we've changed our system, but the costs are out of control. We now spend about 17 to 18% of our GDP on healthcare, which is about $4 trillion a year.
Wow. And what are your thoughts on insurance reform following that logic?
Okay, this is my personal opinion. I mean, in our book, End Medical Debt, we actually have 3 authors that wrote chapters without the other people seeing the chapters because we wanted our different perspectives to be heard. And it was pretty interesting, the different perspectives that we had. It was
I like
my
that approach.
co-founder and and another gentleman, Robert Goff. So Jerry Ashton, my co-founder, and Robert Goff. Robert Goff is from the healthcare industry, and he asserts it's the costs are out of control. Jerry says, hey, healthcare is a right. We need insurance reform, healthcare reform. He's more on the social, maybe even socialist, progressive perspective. I'm more in the middle. I want people not to have hardship from debt. That's what our goal is at RIP Medical Debt, is to remove the hardship of medical debt, not change the system. We're more of a resolutionary approach as opposed to a revolutionary approach. So insurance reform is an extremely interesting topic because we say if we change the system to where you had a government option and no insurance option from private insurers, we might have a tremendously difficult time doing that if we tried to do it. You know, politically, it's very hard to do. And I'm not the expert on insurance, but I know it's broken. The insurance industry is broken. But I wish people were not underinsured. I mean, it's one thing for our country to be uninsured, and it's another to be underinsured. And underinsured, anybody who's out there knows if you make $50,000 and you pay $5,000 out of pocket through your deductible, so you have a deductible of $5,000, you are underinsured. We can't have 68 million people be underinsured. And then you add about another 20 million people that are uninsured, where, I mean, that's a third of our population almost that's underinsured or uninsured. So there's something wrong with the insurance if we have that many people that are going to pay the first $3, $4, $5, $10,000 of their care, and only about 30% of the people ever even reach their deductible.
Mm-hmm.
So what's going on here and these narrow networks blow my mind. 20% of all bills are out of network. Out of network, or these narrow networks, are an insurance invention. So maybe the insurance companies have to be told we can't have these narrow networks anymore because out of network coverage and surprise billing is killing people.
Literally.
I just read, because of COVID, and this is an interesting part too, because of COVID, and we hear every day, oh, all of your bills for treatment and testing for COVID is going to be covered and be paid through Medicare. Now, Medicare is usually just for people that are either handicapped or over 65 or 70. So we're not talking about a big swath of the population, first of all. Second of all, things like the CARES Act, it expired on May 31st. Does anybody know that? So if you get tested or if you go for treatment for COVID, you're not covered under that. Also, the insurance companies have a trade group, and the trade group did a big study on how much was going to be cost shared, how much was going to be shared by the employee or by the patient. You know, what's their responsibility of all this? Well, guess what? At a very low infection rate of about 20%, there's going to be a $20 billion bill that's going to be paid by you and me, but only if we get COVID. So the insurance industry, what's difficult about it, it's not like covering the whole country. And the people that get COVID or have to be treated and have an intensive care situation are the ones that are going to have this $20 billion. The fairness of that is is not to be seen. So we've got $20 billion on people, maybe 5% of the population. Divide it up, you'll see that it's untenable. And, you know, it's that might encourage me to support an insurance reform or make sure people saved their butts off so that they have money for, you know, these eventualities.
So let's shift gears slightly. You mentioned Medicare, and we know that we are currently in, I believe, year 11. It was like over 10 years ago that we signed the Affordable Care Act. What are your thoughts on adding a Medicare option to the Affordable Care Act?
Okay. What's interesting is it's very hard to discern between Medicare for all, universal
Hmm.
health, you
We've
know,
got a lot of names for that.
option.
Yeah.
I mean, it's unbelievably difficult to know the differences.
Yeah.
Even like a Bernie Sanders will say, "I want Medicare for all." Now, Medicare is not a single payer system,
Right.
which is very interesting. People think Medicare, it's all government run. No, it's privately run in a lot of ways. So you've got to look at if an option becomes possible for people, like they want to pay, though they're going to pay,
Hmm.
or part of it might be subsidized for a Medicare option. Doesn't mean it's all government. I mean, I wish what I really wish is that it would be Medicaid option because I worked with AARP, for example, and they do a lot of charity work with their foundation. They not only help the over 50 in their foundation, they help everybody. So we did studies on who has the medical debt, who doesn't have the medical debt, and we're doing an ideation session and we're putting up on the board post-it notes of all the interviews, hundreds of interviews that they did. And I'm looking through all these post-it notes and I'm saying, where's the Medicaid people?
Mm.
They didn't find one person that had Medicaid that had a problem with medical debt.
Wow.
So Medicaid is the best insurance you can get. Now, it doesn't mean that everybody should get it because you have to have low income or you have to be disabled or maybe even unemployed. That's one of my sons was unemployed and he wouldn't take it. So there's a stigma. I'm not going to take that Medicaid. What the heck? It's going to be poor quality. I'm not going to get the right doctor. I'm going to have to wait. I'm like, wait a second. You're in a need. If something happens to you, God forbid, you need to have care. And Medicaid is widely accepted. Now, so a Medicaid option, I think, would be wonderful. Another thing I think would be really important would be an opt-out policy as opposed to an opt-in policy. Right now,
Interesting.
Medicaid, you have to apply for it. You have to qualify for it by going through an application process. That's nonsense because I get medical debt that I buy for people that qualified for Medicaid and either didn't take it or didn't even know they had the option to take it.
Oh wow.
That's an unacceptable amount of people that are missing out on a government service that's for the people that they could use and help their wellness.
Now, Craig, you brought up some terms, and I've recently chatted with Dr. Jody Liu. She's the professor and associate policy researcher at the Party Graduate School. I think there's generally a lot of confusion, and I agree with you. A lot of terms that are often bandied about, like single payer, like universal coverage, and certainly Medicare for All has received plenty of airtime. Should we stop using these terms interchangeably?
Yeah, they're quite different.
No.
As I said before, Medicare for All is not single payer, and the the Medicare option, or like I wanted to call it, have it be Medicaid option, is not a single payer as well.
Mhm.
What we need to understand is first, it is who's paying the bill?
Right.
Now, the bill is so high. So personally, I don't care who pays the bill. If there's $4 billion of expense and it's almost 20% of our GDP, it's too expensive. Doesn't matter if the government pays it, quasi-government and private charity. It doesn't matter. But there are quite a major group of differences between the several options. One allows the people to decide to buy insurance that the government offers. A single payer means that either a quasi-government institution or the government itself manages the healthcare. Now there's another way this could happen. They either pay private enterprise for that service,
To
but they
manage
pay
it.
for it,
Yeah.
or a single payer could be where the government starts to run all the hospitals. So that would be only way you can get healthcare is to go through the government, and there would be no option to go through others. A universal healthcare system would enable you to not only get it through your employer, you could get it elsewhere, because there are issues with trying to supplant employer-based healthcare. First of all, the employers self-insure half of all employee insurance.
Correct.
So they've done a really good job of building the plan that fits their employees. Are they going to let that go? Are they going to let go that benefit? If you did take that benefit away, which is probably around 20% of each employee's compensation, would they be compensated 20% in salary to make up that difference? So do people really want to lose 20% of their so-called income? No, I don't think so. But also, I, as a small business, small charity with less than 20 employees, I have a very poor selection of insurance. I mean, that's wrong. That I can't let my employees have just as good insurance as the teacher plans, as the employer plans. We couldn't get.
You can't access it.
We can't access. It's not available.
Yeah.
So these payer plans, like a universal health plan, would actually end up making economies of scale and spread the risk amongst all of the people. So in a way, we all would be paying and subsidized for people that might not be healthy, but we don't know when we're going to be unhealthy. So what's the difference here? We've got to really decide, should all the expense be put on just the people that get ill, or should we try to share? And this is my personal opinion. Maybe we need to share a little bit more. And maybe it's selfish. Until we get sick, it's kind of selfish.
So, Craig, let's shift back to you and your colleague Jerry Ashton. You both came together to start RIP Medical Debt in 2014. You both realized you were uniquely qualified to help these people in need. Can you please explain how you blended your expertise as well as compassion in developing this truly amazing organization?
Well, thanks. Yes, Mario. We were in the collection business, which means collecting medical debt, because half of all debt in this country that's in collections is medical debt. So believe you me. And almost 60% of all the bad marks on credit reports are medical debt. So go figure, this would be the biggest part of the collection industry. The collection industry, which I was part of, makes $8 billion a year collecting medical debt. Now, I didn't like it at all. Matter of fact, I wanted to get out of it for years, but it's what I knew. And you do what you know. And I stayed in it for over 25 years and was banging my head into the wall every day. It was skullduggery, actually. It's very hard to collect medical debt from people that can't pay, which is predominantly the debt that's out there. Jerry Ashton, on the other hand, loves collections. He's one of the best collectors I've ever known, but he's compassionate. He cares, wants to get to the bottom of it and help the customer pay. Now, we both thought we were doing good, not only good for the hospital and the doctor, and he likes collecting for doctors better than hospitals, but we didn't realize the impact, the negative impact that medical debt has on people. I mean, it's destructive. But we kept doing it because we thought we were doing a service.
Mm.
We even thought we were doing a service for the people, which is kind of ironic, help them complete this bad debt that's sitting out there on their head. Interestingly, we would have never come up with a debt abolishment or forgiveness company, charity. We knew collections, and that's all we were going to do. When Jerry introduced me to this concept, I was like, this is the dumbest thing I've ever heard.
Wow.
Now,
That's some origin story. Yeah.
I couldn't believe that somebody would forgive debt. Why would you do that? It's the dumbest thing I've ever heard. When you can collect it. Now, but only about 15% of all the debt we ever got was collected. So you got 85% of the people are being called and done for collections for 5 to 7 years. It is pretty, when you think about it, it is
Daunting.
pretty uneconomical, and it's kind of brutal that it has to last that long. I don't mind it lasting for a couple, 3 years, but if it goes on for 5, 10 years or more, it's pretty bad. Well, another nonprofit actually decided to do this, abolishing medical debt, among student debt and other debt. And then they stopped doing it in the end of 2013. And Jerry and I looked at each other and we said, we can do this. This is the business we're in. What the heck? I was in the debt buying business. So I knew how to debt buy. I knew how to go to the hospitals and the debt buyers and buy their debt. And this is how the debt buying industry works. Let's say a hospital has $100 million of debt they can't collect. They go to a debt buyer and say, how much will you pay me for this debt? And the debt buyer comes in, just like a contingency collection agency would. What do I expect to collect on this over the next 5 years? If the number that they come up with is 15%, they're going to pay about a third of that. They're going to pay 5%. Now, some of the debt that we buy, which is like 1 year old or 1.5 years old, will cost us over 5%, maybe even 6% of the face value. So $6 million of the 100 million is what I'd pay as a charity. Now, some debt, you're only going to collect 3% if it's older. If it's 3 years older, might pay 3%, might pay 1%. If it's more than 4 or 5 years old, I might pay 0.5%, 50 basis points. Now, on average, I pay about 75 basis points for the debt that we buy, which is less than 1%.
Wow.
You add my other costs of data, because I have to qualify the people. I'll tell you about in a second.
Yeah.
I have to pay the people that find the debt, because we've only got about $3 or $4 billion of debt that we can buy at any one time, which is not a lot. Might sound like a lot, but we've abolished $2 billion already since we started. So it's we better get more debt, and it's plenty out there. Believe me, it's just finding it. So what ends up on average is we're able to abolish $100 for every $1 that we get from a donor. So that's like $10 abolishes 1,000.
Wow.
$100 abolishes 10,000. 10,000 abolishes $1 million. So there's such leverage in this. And I used to buy the debt and collect on it for a profit. So now we use it as a social profit. But it's the same skill set. It's the same data. It's the same systems. I converted my debt collection system, one of the most advanced systems in the world, to a debt forgiveness system. So it was amazing. I could send out 10,000 letters a day. And we've helped over 1.5 million people thus far. And we're qualified to do this, uniquely qualified to do this.
So, Craig, can you share with us and our audience some of truly extraordinary achievements. You've shared all of them uh, to date over the history of RIP medical debt. But let's get inside the numbers in particular. I know 2019 was particularly a tremendous year for your organization.
We were able to abolish over $1.5 billion last year, 2019.
It's extraordinary.
It's unbelievable. Jerry and I, when we first started, we said, let's make an audacious goal. So what about $1 billion of medical debt? Now, to put that in perspective, the first 3 years we did $15 million
Wow, that is
of debt
perspective.
abolishment.
Wow.
So that, and that was donated to us by John Oliver on the HBO special Last Week Tonight with John Oliver in 2016. So this is a difficult thing to do. The hardest thing is to raise the money, of course, because I can buy the debt and I can find the debt. Um, but about a third of that, $500 million, came from faith-based organizations, churches, synagogues, mosques throughout the country. And it's like a basic tenet to help others. It's a basic tenet to forgive debts. It used to be release the slaves. Well, when you forgive a debt, you're pretty much releasing a debt slave and trying to get them back to where they were. So in a way, this is so satisfying. So
I can't even
uh,
imagine. Every day you are truly doing God's work in many many ways.
no, it's
Uh,
amazing. Last night, I was up working till about 11:15, and I woke up at 6:15, and my wife's like, "What are you doing getting up so early?" I said, "Oh no, I got to go get some stuff done."
yeah, use the tank.
I
It's
wake
just
up every day like I can't wait to get started on the day. It's like people look at me like I'm nuts,
yeah.
but it's compared to collections, this is like nirvana. This is heaven. It's unbelievable.
And it certainly has to be completely self fulfilling in terms of just the feeling that you get every day, and the 20 or so people that you have in your organization, knowing the good that you're doing, and you've expanded both the debt buying opportunity and your fundraising efforts, and I know the fundraising efforts have increased greater than 100% annual compound growth. Tell us about these two areas. First, if you could explain it to our viewers who don't understand these financial mechanisms, and maybe have only done basic fundraising for their children's school or for their own
Sure,
charity.
sure. We stunk at raising money in the early days. I think the first year we raised $3,000. Then we got on CBS and we raised $15,000 to $20,000. Then the next year we got on the HBO special I was talking about, and we raised $250,000. But that's when things started to get interesting. We raised 2.5 million in 17. We raised 5.5 million
Amazing.
in 18. We raised 13 million in 19. We'll probably raise close to 20 million this year. This is all like meteoric growth. Um, Ironically, it's all inbound.
Mm.
We haven't done any solicitation of
Wow.
people to donate to us. It's
I'd like to
bizarre.
do some here, so definitely let's let our viewers know that if this is an area that they're interested in supporting, how can they reach you guys?
They could go to www.ripmedicaldebt.org. And we've got a real interesting funding going on right now uh, called Helping COVID Heroes.
Yeah,
And
and
what that,
that's where I want to take this opportunity
this is
next.
so incredible
Yeah.
because we run by data. TransUnion is a big data source. Exact Data is a big data source for us. These are partners that are key to us. Initially, they were partners to help make sure we found the right address for people. TransUnion is one of the best partners we've ever had. They care so much that their CEO was talking to his whole sales group about supporting RIP medical debt. I mean, this is quite amazing how much they support us. Now, initially, it was to qualify the debt, because we want to make sure we're doing business with people that are in a charitable class. Are they low income?
Sure.
Are they in hardship? And those, we use data for that. Then we started thinking, well, what about data like, is it a single mother?
Mm.
Is it the elderly? Is it a veteran like military? Um, we started adding data to this, to the system. And now we could focus on those groups. So I went to TransUnion and Exact Data and I said, can we find nurses and paramedics and all the technicians, radiology, because that's a big thing. So these first line healthcare workers, the home healthcare workers, the nursing aides, and these, unfortunately, these essential workers are the lowest paid workers in the country. Now, nurses might be getting up there a little bit, and there's 3 million of those, but EMS workers are mostly in the poorest areas because you don't need as much training. So let's just say we took all these frontline and you know, first responder people, and we were able to add all these licenses because they're all licensed, and all these licenses and vocations to our data, and we're now able to buy debt of just those people and abolish them. We've abolished about $55 million of debt, like just last week,
Wow.
for those people. Then I said, well, what about a second tier of people, the occupations that have been hard hit? The barbers, the nails people, the waitresses, the grocery clerks, the people that are just in front of us and going and going and going and going. So I added these occupations, like about 200 occupations. And that's the second tier of people. And the third tier is just where is the hardest hit places in this country, and we're going to buy debt in those regions and abolish it. We're probably going to, we raised about $1 million so far just for that fund. We'll probably abolish, I don't know, 250 million dollars of debt in the next few years. All for that one fund.
Yeah.
So it is pretty cool. You can give $1. I mean, I get $1 donations. I really do.
Wow.
Or we do. I mean, because they know that $1 is going to abolish 100. Usually you say, what the hell? What's $100?
Right.
People really care about $100 bill. I get thank you letters. We get thank you letters from people for $100 bill.
Wow.
I would have thought it wouldn't have mattered a thing that we abolished a $100 bill. Now I say, I'm going to buy that debt,
Right.
that emergency room visit that was very low. I'm buying it. It might only cost me, $1, but or 50 cents, but I'm buying it because it matters to somebody out there that you care. It actually is it isn't necessarily the bill that's getting paid. It's that someone cared to pay their bill that they couldn't pay. It was a stigma. They were embarrassed. And most people want to pay their bills. Why do we have a system that has created over the last 7 years $1 trillion of debt that people can't pay? And this is on their kitchen table.
Right.
This is not like, people don't throw away the bills.
No, it stares right at them.
They have a pile, and every so often they go through that pile, and it bothers the hell out of them that they can't pay. It is a burden beyond comprehension. 75 million people have a bad mark on their credit report. That's medical debt.
Wow.
15 million people, it's the only bad mark they have is a medical debt. And guess what? $100 bad debt that's in collections for medical debt is just as bad to your credit rating as $100,000 bad debt. They're treated exactly the same. It's astonishing. So yeah, we're happy that we're able to help. We do abolishment by 4 ways. By geography, so your region, maybe the 13, 14 counties that you live in. Also then by group, so it's veterans or these COVID heroes. Then it's demographics. Are there single mothers? Are there teachers? Are there, what else would be an example? The elderly, by age, or by social determinants of health. Are they socially isolated? Are they transportation insecure? We know financial insecurity is what we look at. But the social determinants of health, debt is a social determinant of health.
Yes, it is.
And the final way is by ailment. We just bought a portfolio of addiction, opioid addiction debt. Can you imagine somebody being in addiction and having a $50,000 bill
Mm.
that they can't pay because they're out of work because they're ill or have mental illness and that's what caused the
Or just pure
addiction,
addiction.
or
Yeah.
just pure like addiction of alcohol or something. So yeah, so you can do it by those four ways, and it's going to just get more and more sophisticated because
Yeah.
we're small, under 20 employees. I bet we're going to be over $100 million of donations probably within the next 3 years. That's how it's going.
Well,
And if
let's
that'll
definitely hope for
abolish,
that.
you can't believe, that will abolish $10 billion in medical debt.
Wow.
And about 200 to 300 billion is created each year. So that'll start actually impacting the overall medical debt. Because my goal, our goal, at least I'll tell you personally, my goal, my vision, is that we reduce or eliminate hardship of medical debt by this charity. And I'd like to one day get to where we could abolish $200 billion a year, and it would only cost about $1.5 billion. We might become the biggest charity in the world, but if that's what has to happen, that's what has to happen.
Well, we will certainly invite you back to celebrate that milestone, and we certainly will have a tremendous amount of viewers viewing that interview. We may have to do that one live, Craig. So,
Oh, I'd love to be there.
yeah, and
We'll
pop some
be,
champagne as you reach that 1 billion.
yeah,
But
because it'll be the 50th episode of you know, your setup here.
yeah, I hope Stealth on Health is certainly still viable at that point. I know RIP Medical Debt will be, and I just want to reiterate for our viewers again, because of coronavirus, RIP Medical Debt has created a very special fund to wipe out the debts of those frontline workers, and the fund has been labeled Helping COVID Heroes Fund. And you can support that noble campaign through the RIP Medical Debt website. But Craig also mentioned there are different areas that you can help if you have a particular interest. And Craig, if you can, for our viewers that are looking to donate, can they donate specifically in the county and specifically to the target audience that they're interested in supporting as well?
Yes, they can. I mean, look at geography wise. There's 3,000 counties in the country. You have to realize that many counties, we have hospitals and physicians that don't sell their debt.
Mm.
So the only way that you can find out is if you call us. We don't have a map yet. One day you'll be able to say, I want to abolish debt in this county, and you go on the site and you just do it. It's not there yet. We're working on that.
Okay.
But yeah, you can. Um, what I recommend is taking what they call a DMA. A DMA is a designated market area, which is there's about 15 counties that encompass this DMA for each area. I don't care what county in the country you live in,
Mm.
you have a DMA. And that county, I probably have at least $1 million of debt that you can abolish for maybe $10,000.
Wow.
Now, the minimum is $15,000 to target your, medical debt. You can't donate $100 and say, I want this to go to this county. We just can't do that yet. So the minimum is 15,000. Um, I mean, yeah, minimum is
Certainly, there's
15,000.
individuals and organizations that are looking for the benefits of that type of donation. So that is quite possible.
Oh, it is. I also want to impress on your viewers that this is a random act of kindness. You can't apply for our help. I get tens of thousands of letters saying, would you please help me? I mean, it's heartbreaking because
Mm.
I originally thought that if I took all these people in and got their information, I'd be able to go and get their debt. No, no, it was so hard to do. So I had to stop doing that. But I get tens of thousands of people asking, can you abolish my debt? And what I tell them is this: can you imagine me going to a hospital with your bill and knocking on the door to the collection person, the revenue cycle person, and saying, I'm a charity, RIP medical debt, and I have this person that's really resource challenged. I'd like to buy their debt or even pay their debt off. I don't pay debt off, I buy it. But let's just say I wanted to pay them. The $1,000 bill, I want to pay you $10. They would laugh at me, wouldn't they? $10 for a $1,000 bill? Are you kidding me? So I can't do that. I have to add tens of thousands of accounts
to build it up
together in order to get this deal that we get from the hospitals. And by the way, it's not a bad deal for them.
Right.
It might actually be 25% of their surplus for the quarter, what I give them, what I pay them. So this is like their profit surplus, if I might.
That previously would have just gone.
It wouldn't have been there.
Yeah. No.
There was nothing. It was only on the people's head and burden, but it wasn't being collected on. So I want to get rid of it for a low cost, but I want to get rid of it. And they can get $1 million for every $100 million. The hospitals should be knocking my door down because they get credit for this on their charity care.
Well, let's hope they all start calling so that we can.
They have to call because otherwise I have to call them. It's just like me bringing a $10 bill with for a $1,000 bill.
Exactly.
It's so hard. Hospitals have to start calling me now because I have had a few, but I haven't had this 5,800 hospitals. It's their responsibility to start calling me because we need to abolish debt throughout the country. So thanks.
Sadly, I think you're going to get a lot of calls because there is that large volume of medical debt. But the silver lining is then you get to do the great work that you and your team can do to help bring that to fruition. So I know that this is a statement that you made in a recent interview, Craig, and I'm absolutely fascinated by this. You said the debt of COVID-19. There's so many mixed signals about it. Are we going to be charged? You covered a little bit of that with regards to the CARES Act at the beginning of our interview here today, but can you help separate some of the facts from fiction for our viewers? What do we know regarding deductibles, co-pays, etc., regarding COVID-19 right now at the moment?
It is so confusing.
Yeah.
On one hand, you have the government, President Trump and Pence saying that every single bill will be covered for treatment and testing. And I've got bills. I actually have bills in my hand that I've got from people for COVID treatment and COVID testing. And the bill and Medicare says denied on the EOB, explanation of benefits. So even the hospitals and the doctors are confused. So let alone the patient. You can't even ask the doctor or find out from the hospital whether people are going to be billed. So nobody really knows. All I know is, how a lot of times in the stock market or in a market, the market knows, or when you look at the safety in numbers or the crowd knows, when you add the crowd to something, it knows. Well, there's the insurance industry knows exactly how much the people are going to pay. And at each varying degree of COVID-19 infection. If it goes to 60% infection rate, there's going to be over $100 billion of medical debt that the people will be responsible for. I said before, at a 20% conservative low infection rate, we're going to have a $20 billion bill, personally, you and me, if we get it. So I know that is what's going to happen. The insurance companies know exactly, they're actuaries. They know exactly what's going to happen.
Sure. They've got those tables. They figured this all out.
They figured it out.
Yeah.
No one hears about it, but they figured it out. That you can go on the internet and look up American insurance plans or health insurance plan, and it's right there. It's right there. It'll show you exactly what I'm talking about. Now, as far as people being able to ensure that they don't get this big bill, they've got to find out what their insurance companies are doing about it. Now, the insurance companies, if they say they're covering something, they are covering it. They are not going to renege. There's a really good website, and just look up insurance COVID plans, and you'll find this 3,000 insurance company list of exactly what each insurance company is covered. You know, whether Aetna says we're going to forget deductibles, or another one says we're going to waive copays. Remember, 68 million people are underinsured. That means they're going to pay for everything up to $2, $3, $4, $5,000. So any COVID, if it's chargeable to you, you're going to pay the first thing. So they might have waived deductibles. They might have waived copays. They might have waived co-insurance. Each one is different. There's no uniformity. You got to find out. Your insurance website will tell you exactly what's covered. Medicare, unfortunately, is a different story. I've looked on Medicare. One lady had a CT scan. I have the bill. Not being covered. All the other things are covered. They talk about it. Now, a non-laboratory diagnostic like a CT scan or any kind of a scan, you know, might be the way that you diagnose whether someone has COVID. It's treatment. It's supposed to be covered. But nowhere in the Medicare website can I find that it's covered.
Wow.
So you're going to have to see, well, when a doctor says, I want to do a CT scan or some other non-laboratory diagnostic, you better find out, is this going to be covered? Do you have an option, a different option, or what's the benefit of this? I mean, these machines are $1 million a piece, and they've got to pay for them some way. I hope you're not paying for it.
So, well, I hope once
and the out of network,
not continuing to pay for it as well.
Yeah, the out of network, where if 20% of all bills are out of network, I can imagine that many more than 20% are going to be out of network when it's the COVID. Now, insurance companies are waiving the in-network requirement, but you got to know if yours is or not. So yeah, there's landmines out there, and hundreds of billions of dollars at stake. I mean, COVID has the chance. It has the chance to be. Remember, I said that half of $200 to $300 billion is owed by people after they've paid everything they could and all insurance is paid. Well, can you imagine? COVID is almost a third to a half of that.
Wow.
In one illness.
And just such a short period of time that we've seen.
In a short period of time, people. I'm not going to be able to buy that debt right now, but believe you me, I'm probably going to buy $1 billion of it or more in the next year. Yeah. $1 billion I'll be buying, or maybe two. Wow. It's sad, but at least I'll take the hardship away from those people.
No, thankfully. You know, Craig, we talked a lot about those individuals and those individuals who reach out that we can't help on an individual basis financially because of the structure in which RIP Medical Debt buys large sums of debt from institutions. More broadly speaking, any recommendations, helpful tips to viewers who may know people that may not be able to pay their hospital and medical bills? Are there things that those individuals can do? Anything that they can do themselves to negotiate? Any helpful hints that we could provide to them?
Sure. Some of the most unknown benefits deal with the government or the hospital actually giving you financial assistance. Every hospital, no matter whether it's a private hospital and it's for profit, or it's a nonprofit or a government-run community hospital, has a financial assistance policy. It's often called charity care. That means that you can't be denied, service that's required, or I don't know I can't remember the word. service that you need that's not an elective type of thing. You're going into the emergency room. It should be an emergent issue, right? So you go to the emergency room. If you don't have the resources to pay, I don't care how much, I don't care how much insurance you have, you can get charity care. Charity care will pay every cent of your bill. You have to make, and each hospital is different, but it's generally 2 times the poverty level and below, you qualify for charity care. Now, unfortunately, it's not an opt-out policy, an opt-in policy, which means you have to apply for it. Some places will do it if you make 3 times the poverty level and below. Some places are 4 times the poverty level and below. Do you know what 4 times the poverty level and below is? It's over $170,000.
Yeah.
So for a family of, say, 3 or 4.
Yeah.
So we're talking about significant support if you need it. I mean, of course, don't ask for it if you don't need it. Everybody has different needs. So that's the first thing. The second thing is, you better know whether a doctor is in network or not, or a hospital is in network and the doctor in the hospital is in network, or the procedure in the hospital is in network. You better understand your insurance. What is my copay? What is my deductible? What is coinsurance? You better know what those terms are. I don't think I need to tell your audience, but you know what? Maybe I do, because even people that know this stuff, or should know this stuff, and are well educated, just like put it aside and don't even pay attention. They don't read the book, just like the manual of your new dishwasher. You know, I don't need to read that. I don't need to read that.
Or your car. I put gas in it and it goes. I don't need to know anything in that
Know
compartment.
your car.
Yeah.
I mean, know everything. You can't know everything, but when it costs so much, and you're paying so much for the insurance, you know, you're paying $20,000 for your insurance. It's crazy. You better know what it covers. So those are 2 things, and you have to realize that there are landmines for certain ailments: dialysis, cancer, anesthesiology, and addiction, mental health. You know, those are the biggest areas for out of network. What else can help? The other thing you have to do is communicate with your providers, especially if you can't pay. Every single provider, unless you owe like $50,000, sometimes they won't take $5 or $10 for that. But every single provider will work with you, but put it on an auto pay. Make sure that $25 gets to them every single month, or whatever frequency you've agreed to, and they will work with you. You'll be so happy that this gets paid for, because the average bill is like $250.
Wow.
Even if you pay it $10 a month.
Pay it on installments. Yeah.
Come on.
Yeah.
Now, I've seen people that pay too much on installments. Don't ever spend more than 2.5% to 3% of your gross income monthly. If you're paying more than that, you actually become in hardship. It's researched. Now, everything differs. You might be only can pay 1%. Some people can pay 5%. Everybody's different. But don't pay a cent if it's going to put you in hardship. And what I mean by that, you're not going to go get care. You're not going to go to the doctor. You're not going to get a prescription. You're not going to eat well. You're not going to be able to put tires on the car to get to work. That's hardship. You can't pay your utility bills. Hardship. You know when you're in hardship. Don't pay a bill if you're in hardship. Any bill, collection bill. But communicate what you're going through. Communicate that you are in hardship, and you will pay when you can, and you can do whatever you need to do. But I'll talk with you about this anytime, and you can check in, or I can call you. But make sure you don't just put it under the pile and never pay attention to it. Also, you can negotiate any bill, probably down to 40% of the bill. Not like me, you can't get it for 1, 2, 5, 10%,
Right.
but you can get it to 40% without a doubt. I mean, there are debt settlement companies. The reason why we can't do what the debt settlement companies do, and they make $5 billion a year helping people settle their debts. $5 billion. It's quite an amazing number. They do it by writing to your creditors and your providers. And over half of those bills are medical debt. So they're getting these discounts. And the average discount, 45%.
Wow.
But you pay about 20% of the difference that you didn't pay. So you are paying, 12 to 15% of the money you saved. So you are paying a lot to that debt settlement company. So do it yourself.
Yeah.
Send them a letter.
Pick up the
Call
phone,
them.
call them. Yeah.
Now, there's another thing. Let's say you went to the hospital when it was a real emergent issue and you decided, I can't deal with this now. I got to get in and then I'll deal with it later. And you deal with it later. You get the bill. And you're like, oh my God, it's $2,000 for a broken arm. Well, what the heck? I can't pay this. I'm out of work or I only make, $30,000, I'm a teacher's aide or something. And let's say if you can't wait like 6 months, 9 months, you can, but don't.
True.
Don't wait until the 240th day, because that's like the end of the rope. Call before the 240th day and make sure they know that you qualify for their financial assistance. If you do, if you make 2 times the poverty level or below, they will change your bill to charity care and remove it completely.
Wow.
So it all is not lost because you didn't apply, when you went. You have some time, and wait till your insurance company pays the piece, 90 days at least, and then start researching. Wait till you get the next bill. If you get a bill and you can't pay it, call up and ask for an itemized bill. You'll see what procedures were, how much insurance covered, or if you're self-pay, uninsured, how much you were charged. Because the hospital cannot charge you the rack rate. You remember you used to go to the hotel, and on the back of the door, it said how much this room costs,
Standard rate, yeah.
and it said $500. You're like, who pays $500? I paid $150.
Next to the innkeeper's regulations from like 1830.
Yeah, it is, right? So you have a rack rate for billing too. You have what they call a master billing, okay? A charge master, they call it. Well, this charge master has all these rates for all the procedures that you get. Now, as a self-pay person, a person that's uninsured, they can't charge you more than is reasonable and customary. That means kind of what the insurance company is willing to pay them. That could be half of the bill. You see it all the time on your insurance if you have it.
Yeah.
The bill was $1,000, the allowable amount was $400, and we're paying this. And then you get your portion. Well, the same thing is for a self-pay. If they didn't put the bill reasonable and customary, you got to call up and say, this is not reasonable and not customary. And you could look online, Google it, for this procedure, what's reasonable and customary. And it'll tell you. If you know what you're going for to the hospital, you can shop around. Say, what's the CPT code of the procedure I'm getting when I come in this week? I want to know all the CPT codes that I could get. And what do you think I'm going to be charged? Bing, 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 bing. Then you go on the internet. Now, you can't always do this. Then you go on the internet, what's reasonable and customary? And you find the 4 hospitals in your area, if you're lucky, and it tells you the rate for each one of them. So you can shop around like a car. Why should you go in blind?
Right.
So
We need a greater transparency as well. Yeah.
Transparency.
Yeah.
The other thing, only about 10 to 15% of providers, hospitals, and doctors have the collection agencies that they use report them to the credit bureau.
Hmm.
You better know if you have anything on your credit report from any of your providers that are placed for collection, because it's affecting your credit rating. One bad mark of $100 or more, that you owe $100 or more, will reduce your credit score between 30 and 100 points.
Wow.
Now you might say, 30 and 100 points. I've had some people tell me it's dropped their credit score 150 points.
Wow.
One $150 bill that was a mistake that they didn't even know about. So you better get your credit report. Only 20% of the people in this country ever even look at their credit report. But why you look at your credit report is because of this. It's tied to all the costs of your credit. It's tied to your credit card. It's tied to your auto loan. It's tied to your mortgage. Now, if you knew what 100-point drop did, it increases your credit, it increases your cost of credit by over 30%.
Wow.
If you drop another 30 to 50 points, it's another 30%. Another 30 to 50 points, it's another 30%. You could be paying 4 times as much as the guy with good credit. 4 times.
Because of one small bill.
Because of 1, 2, 3 bills that you're not paying that are in collection. So you better know. The other thing you should know is when you get a collection call, you have 30 days to dispute that bill. So what you should do is say, what is this bill for? I need an itemized bill because I want to know. If you don't know, if you do know, don't play around. If you do know, but you dispute, because 70% of the bills that you get have an error. That's why I tell you to get an itemized bill. I didn't get this. I didn't get this. I want these CPT codes off. This guy was in network. This should be covered.
Right.
You better do this before it gets to collection.
So do your homework. Yeah.
The problem is there's only one collector for every 8,000 accounts in the hospital system.
Oh my.
So they use collection agencies like a collection group. So if you get placed for collection, don't be surprised. They placed me for collection. Well, because they placed your collection because they don't have enough people to even call you.
Right.
Now, but that's going to go on your credit rating. So if you have a dispute, you better dispute it before the 30th day, because they can't put you on a credit rating if you've disputed the bill.
Oh, that's a great lesson learned.
So my partner and co-founder, Jerry Ashton, says you should dispute every bill. Do not dispute every bill.
Right.
Don't abuse the system. Just work with the system. These people, I was one of them. They want to help you. I know it causes a lot of harm, but it's up to you as the viewer not to cause yourself harm. You can't pay a bill that's going to put you in hardship. I don't care how many times they call you, and they should never expect you to. They wouldn't. Should you?
Right.
No. And they're people just like you and me.
No, I love that. I absolutely love that. Thank you for those incredible words of wisdom, as well as those helpful tips. And Craig, we haven't spoken much about you. We've spoken about your organization, certainly everything that you do. We spoke a little bit about the healthcare system overall, and certainly helped define some of these important terms and identify that they shouldn't be used synonymously. Let's talk briefly about you and your experience. When did you first recognize the challenges regarding medical debt?
Recently, like 7 or 8 years ago.
Wow.
It's hard to believe because we've had this problem
building up. Yeah.
It's been building up. Regarding me, I'm an economics guy. I have complete faith. I have a wonderful family that supported me. This is starting anything is hard. Starting a nonprofit is probably the hardest thing I ever did. Besides being married, that's really tough.
That's a labor of love, though.
That is unbelievable. I have 5 young men.
Yeah.
Um, they're all amazing kids. I think being I disliked collections so long, it was probably because I really wanted to help people. I mean, my goal was to give $1 million away each year. That was my goal as I started out in my career. And I didn't do that. And I ended up saying to my wife, I said, I might as well go into a nonprofit and make it official because it was hard to make a profit
Right.
in the for-profit world. But I'm happy where I'm at. I wasn't happy where I was before. Now I'm ecstatic. You just can't beat helping people, really helping people get out of a debt that they can't pay or remove a hardship. I've been in hardship. When we started this company in 2014, we went below the poverty level.
Wow.
We used every savings we had. We hawked every asset that we could hawk. Now I paid it back. My wife is happy about that. But you have to do everything in your power to make it work. I mean, if you think you're doing something that's great, like you have to stick with it until it works. Now you can't do it for more than a few years, 4 years maybe, because then, and I went to my pastor, I went to my best friends and say, I'm not providing for my family. I'm not, am I doing the wrong thing? I mean, if I went past 3 years, 4 years, I think you got to think you'd be living in a hut and, it'd be really bad. I mean, I'm able to take a tremendous amount of pressure and take a tremendous amount of hardship, but it's not fair to the other people in your life. So you do have to know when to fold up, as one of my favorite songs makes out. But yeah, I'm just a happy guy that's doing what he loves, but doing it in the business that I knew my whole life. So if there's somehow that you can do what I do, like flip what you were doing and then do it where it makes you even happier, but you're using the same skill set, you got to do it.
And benefiting so many.
Yeah, you have to do it.
Yeah.
There's no way you can not do it. And it's a risk. It'd be great if you planned for this risk, but even if it's a risk, you've got to take it and make it work. But there's one thing I would do, is raise the money first. Like, raise the money first. Be so adamant that you get donations from people before you do it. Because that's not like only starting a business. That's making sure that you have the ability to make it work.
You stay solid.
You've got to raise the money.
Yeah.
You've got to raise the money. At least the first year's worth of money before you do it. Because we had to grovel and hardly eat, to get it to work. But I think there's people out there that would support you. If you believe in something enough, you can sell people that have the money to back you. I have no doubt. You just have to have unbelievable faith in your ability, and that what you're going to do is going to make a difference. And then you'll have people backing you like crazy.
Well, you have certainly made a difference in the lives of so many, and you've had an incredible array of volunteer as well as professional roles. This isn't Craig Antico's first rodeo in terms of giving to others. I know you've had incredible charitable works that you've done across the last 3 decades. RIP medical debt aside for a moment, Craig, which experience do you believe best positioned you for your success that you're experiencing today?
Well, working with Jerry Ashton has probably been one of the most important things that I've done. Being a deacon at my church has probably been one of the most important things, and influential things that I've done. Um, what else? Being a husband and a father probably is one of the most important impacts. Um,
Any professional role or any specific
yeah,
part of the
being
role?
being in the collection industry,
Yeah.
as much as I disliked it, I wouldn't be able to do what I do
Sure.
without all those things. I mean, if you saw the movie Slumdog Millionaire,
Yeah.
where all these little inconsequential things and tidbits and people you meet and things you do and where you go, like all of a sudden become all the questions to who wants to be a millionaire. Like every single question was part of your life. Well, everything that I'm doing right now, since the earliest days I can remember, have led me to what I'm doing now.
Mm.
So professionally, I mean, I'm, I don't really usually say it, but everything you do makes a difference about what you do. Like it's like
I like that.
every person you
Yeah.
meet makes a
I may
difference
quote
in
you
your
on
life.
that.
What?
I may quote you on that. I'll attribute that to this conversation.
Every person you meet, I don't care who it is, it's the
Yeah.
janitor, it's the person on a homeless person, like you get a new perspective.
You definitely do.
I need new perspectives. I need new perspectives. I am so biased. I am, I don't realize, look, I didn't even know that medical debt existed that hurt people and I collected it, but I never thought of it that way.
Wow.
So that's preposterous
Yeah.
that I didn't think about that, but I was oblivious. So we're oblivious to a lot of things. So I am still oblivious to a lot of things. And I hope to God that I encounter people, everybody we hire brings us a new way of doing things, brings us a new perspective, helps us do a new thing with a new group of people, a new donor, a new healthcare provider,
Mm.
a new way of running the business. I mean, we say, Jerry says, we don't say, we put the people on the bus and we hope we're putting the right people on the bus. Like, and it gets us where we need to go. So it's serendipitous. We just know that the person that comes to work for us is going to make such a difference. And that's what happens.
That's
So all the way from that. Oh, and by the way, I was born premature, 3 months premature. I was given my last rites. I was under 2 pounds and 11 inches, like a chicken, right? And I survived. And so what I say is that everything else is gravy. It's a miracle. And I expect miracles and they happen all the time.
wow.
So that's me in a nutshell. Expect miracles and be miracle ready, looking for them because they're out there.
Wow.
That's
Wow.
that's really cool that you asked me about me.
Yeah, no, I
Most
think this is
people don't
important.
really ask about the me.
This is important. I want to dig in a little bit more specifically into the source of your inspiration. You called yourself the economics guy. For your studies, your career in finance. Where was the root of that?
Well, I think I'm just inquisitive. Um, I like I like to have evidence.
Okay.
I'm a very analytical guy, but also a generalist. I'm a kind of weirdo. I do both, macro and micro.
Hmm.
It's economics,
Shift
behavioral.
seamlessly between the two.
Yeah, I mean I like balance.
Yeah.
I like to have balance. I like to have balanced perspectives. I like to have facts that help me see different sides of things. We do randomized controlled trials on every debt portfolio, large debt
Wow.
portfolio that we buy to see what's making a difference. Is the small debt compared to the big debt, the older debt? We even get debt sometimes it's 10, 15, 20 years old.
That's
And it
amazing.
makes a difference to the people. How could that make a difference to anybody?
Yeah.
Well, maybe it makes a difference. So We're going to test it out. Is there evidence? We have research that's coming out at the end of this year from the major universities for wellness about medical debt and its relief. What now? We can think that it makes a difference. Who cares if we think it makes a
Right.
difference?
You could think,
We
you
need
could feel. Show
evidence.
me the data. Yeah.
Show me the the foundations that
Yeah.
we've gotten a foundation grant for 3 million. We've gotten a foundation grant for over 3 million, but it isn't until we give them the evidence that we're going to get the 10, 20, $100 million donations that can make impacts beyond comprehension. That's why evidence is needed. So I'm always searching for evidence because I look at my customers
Mm.
and I say, what do they need to support me? Or what evidence do I need to support my views? I can't keep a view if it's not backed by evidence. I need to look at surveys. I need to look at, um, statistics. I, I need to know facts in order to build my opinions.
Mm-hmm.
Because there's what happens and then there's the facts. Like, don't forget, what happens is a fact. The story you make is an opinion.
Yep.
It's made up. So try to know what's real and what's made up. And I think that's why I go into the depths of research and why I'm inquisitive. I'm a voracious reader. You heard and saw how many statistics I have about this problem, about the people, about the hardship. So I definitely look at those figures, but then I get the letters and I get the thank you letters. I get the hardship letters. Those are the soft things. I see the interviews that all these TV stations make. If you go on internet and you Google RIP medical debt, you will see hundreds and hundreds, I mean hundreds and hundreds over the last 3 years, 4 years, maybe even since 2014, because we even had it then, of people saying they couldn't believe when they got this yellow envelope what it meant to them. And could it be real? So I have different kinds of evidence, like testimonial evidence of what we're doing that makes a difference. So I can't wait till we get the fact evidence. It's kind of the same thing, but over a broad scope of people.
No, and we'll invite you back, and we will certainly review that data set once it is received and published, and we'll talk about it here. So I look forward to that conversation later.
Thank you, Mario. This was a great talk. What a great conversation.
Yeah.
I really enjoyed it. It touched many aspects of personal, family, business, charity, caring. Very cool.
And we're not done yet, Deacon.
Oh, I love it. My
Okay.
battery is
Or
running.
should I use the term that I affectionately called my deacon, which is Deke?
Cool.
What are your personal and professional goals at this point? What's Craig Antico wanting to accomplish next?
Well, I'm going to stay in medical for at least the next 3 years or so. There's so much happening here. There's so much problems. Even if we came to a single payer system, we'd have
The whole backlog. Yeah.
$800 billion of backlog,
Yeah.
and it'd still be debt. You wouldn't believe there'll still be debt somehow. Somehow someone will figure out how to do it outside of the government,
It's true.
and people will go and then they'll owe. So I would like to see a real expansion of abolishing debt by ailment.
Hmm.
I want to be able to wipe out debt, all debt of cancer, or all debt of diabetes, or all debt of addiction. I want to wipe out
One at a time.
well, you know what? I can get them all. I can get them all at a time once the hospitals start to give me that data.
Yeah.
It's not like I have HIPAA and I have tremendous systems and, confidentiality, privacy, security of data. That's one of the hallmarks of what we do.
Yeah.
We spent $1 million 2 years ago building that system. $1 million when we were a $3 million company
Wow.
to be ready for the scaling that was needed so that this could become an organization that abolishes 10, 15, 20, $100 billion of debt a year. So that's where I see this going. I see foundations partnering with us, like the American Cancer Society, or AARP for over 50, or the VA for veterans, or DAV, or, whatever you care about. I want to be able to abolish debt of those people. If you care about people that are socially isolated, I want to be able to abolish those debt. I just got $1 million from a person that wanted us to abolish debt for people that lived around soup kitchens. Yeah, food pantries and soup kitchens.
Wow.
And food banks in Florida. And we're buying $100 million of debt. No, yeah, $100 million of debt for them.
Wow.
So we can't do everything now. I have to be careful because we're just too small. We have too small amount of debt. $3 billion to $4 billion is just not enough debt. That's only like 3 million people out of the 300 million people we have in this country. I need 100 million people that I can help. Then I can do things that you can't imagine. But I would like to see that. I would like to see us keep very lean. Our overhead is going down as a percentage of our revenue. Our program administrative costs are going down as a percentage of our program debt, because debt used to be.
So, Craig, on a deeply personal note, many of us have lost colleagues, friends, family. Some of us seen the passing of public figures we admire. Most recently, you're in the epicenter of what has been the pandemic in Westchester County. Have you lost anyone that you've admired during this unprecedented time? And who were they? What was their influence on you, your life, your career? Tell us about the relationship if you've lost anyone.
Sure. I mean, in the early part, I didn't lose anybody, like for the first 2 months. And I was like, this is kind of odd. I mean, none of us got ill. My brother got the infection or virus and recovered pretty much right away. My son is on Broadway, and he auditioned for the Bronx Tale, A Bronx Tale.
Sure.
And he was came in second to getting the lead, which was really pretty amazing. But the guy that he was replacing is now in the hospital.
Oh, wow.
He was misdiagnosed as having pneumonia first, and then they found that he did have COVID. Then he got an infection. He was in a coma for about a month and a half, 2 months. Got his leg amputated. It's just an atrocity. I mean, it's so sad. I hope he recovers. So that's something that we supported through a GoFundMe. I haven't seen many people. I don't know many people that have gotten it. It's a good thing, but it's unusual. I remember when 9/11 occurred, and we lost 7 or 8 people here in Rye, in my city, and I knew them, and it was devastating. It was just horrible. Well, I can imagine that the people that have a loved one that get it and just get so ill or die, it's just devastating. I just can't even imagine going through that. And it's affecting the elderly more than anybody else. And
certainly the lower socioeconomic folks that
I've heard that people of color are getting at a prodigious rate, and we're trying to figure that out. It has, and it may be showing a lot of the disparities that we have in this country in healthcare, because A tremendous amount more people are uninsured and underinsured. Um, Tremendous amount more people have medical debt. I mean, I'm talking about 60% more medical debt than, no, 30, 29, 26 to 29% more medical debt than, you know, people of white communities. So it is affecting the minorities. Latinos are tremendously affected by COVID. Um, so a lot of, and one another reason too is they have the lower paying jobs, unfortunately, and they were the essential
They're the
workers.
essential workers that are there. Yeah.
And nursing homes and nursing facilities, home health care people, 80% of those people are older women. What the heck?
Yeah.
So we have a big problem coming up with the healthcare workers. We're not going to have enough, and we're not going to have enough volunteers. Think about all the people that are volunteering to take care of a loved one, take care of an elderly person. So that's a young person taking care of an elderly person. The young person gets it, elderly person gets it.
Yeah.
That's why a lot of these nursing homes have had such a big spike in this. But I think I went on a tangent, sir.
No, that's quite all right. Craig, let me open up the floor to you for the final word.
You know, Mario, you have handled this so well and asked so many good questions. You're one of the most prepared interviewers that I've ever had.
Thank you.
It's really been a fabulous interview, and I was honored to be on your show. And I'm hopeful that not only the donors, because we do get a lot of donations, we don't need donations, but we would love to have donations. We do get a lot of donations, but the debt. If you know a CFO, CEO of a hospital, you know your doctor, tell them about us. Tell them that we're helping people get out of the hardship of this medical debt. And every single one of them knows exactly what I'm talking about. We have to get through to these hospitals and these doctors and medical groups because they're the ones that can help most. There's only so much I can do. I need them and I need you. So that's what I would leave. If there's anything you're going to do, even before donating, I want you to get in touch with your doctor and have them call ripmedicaldebt.org and get these providers on the stick. They've got to start providing debt so you can be out of debt if you're in hardship or someone else is in hardship.
Well, I think all the listeners to Stealth on Health have some actions to take and some conversations to initiate. And certainly when you're calling about your own medical bill to your organization, to your provider, certainly we're always going to be disputing if you need to dispute. We're always going to be asking for an itemized bill, and we're always going to be asking them about their debt and what you can do to potentially connect their debt to RIP medical debt. So, to all our viewers out there, you have an obligation to Craig, to RIP medical debt, and to what we're trying to accomplish here. And as you all know from watching all of our previous episodes, we're here to educate, inform, and entertain. Well, we've done our job of educating and informing you here today, and certainly we've entertained you a little bit with some of the great stories that Craig was able to tell. Now we're going to ask some help from you, and this is a call to action to everyone who's listening that you can help. If you can't donate, or as Craig said, if you have a person that you know that may be in a position within a hospital, within a medical plan, within a provider, have that conversation, initiate that conversation, and give them the information, because we know that's the power of communication, that's the power of our global village, and we can certainly help out. Craig, thank you so much for the time today. I want to be able to invite you back when the research comes out, and I want to be able to talk with you later this year about that. So for our viewers, stay tuned. Craig, thank you so much.
Thank you, Mario. It was a pleasure. Have a great day.
Thank you. For New Right Network, I'm Mario Nasinovich. To access this episode and other on-demand programming from Stelt on Health, I invite you all to visit newrightnetwork.com. The right voice right now. Thank you for tuning in. Stay informed and stay healthy, everyone. Welcome to the Healthcare Voice of the New Right Network. This is Stelt on Health with Mario Nasinovich.